Hey, this is Mark Perkins, and I'm going to talk a little bit about atrial fibrillation, what I've learned in the last couple weeks, and ways to treat it, the ways to identify it. And I'm going to show you a normal EKG strip and then an EKG strip that's in atrial fibrillation, and go over some of the differences and talk about the ways that we can control the rate and possibly break the rhythm.
All right, so if we look at this strip, it's normal sinus rhythm. And we can tell that because we have got a P wave, we've got a PR interval, a QRS complex, and a T wave. Also, the QRS complexes, the R to R interval, from this point here to this point here is the same distance, and it carries that out the whole length of the strip. So that would be a normal sinus rhythm. The strip on the bottom is showing atrial fibrillation. As you can see, it's quite a bit different from the strip above it, which is normal sinus rhythm. In atrial fibrillation, there is no distinguishable P waves. The R to R ratio is different every beat, meaning the QRS complexes are irregular. Atrial rhythm is an irregular rhythm.
So AFib is a supraventricular tachyarrhythmia. It's disorganized, uncoordinated atrial depolarization coming from multiple foci within the atria. This causes the atria to quiver. It doesn't really contract, and the rate at which it can quiver is 300 to 400, 450 times per minute. It's tough to count, and that makes for all the irregular P waves that you see on the rhythm strip. If your atria is going to be depolarizing that quickly, your ventricles are going to be trying to keep up with that. So, they could be beating 120, 150, even 200 times per minute. And when you start getting up into those numbers, your heart is going to eventually wear out. And so one of the main focuses of the treatment of AFib, maybe the primary objective, is going to be rate control. AFib is classified into four types. The four main types, there's a new onset, newly discovered AFib. This would be somebody that's never had AFib before. The second type is recurrent paroxysmal. It's 2 or more episodes of AFib, and it's self-limited, so it comes out of the AFib rhythm on its own and returns to normal sinus rhythm. The third type of AFib is recurrent persistent AFib, and that's 2 or more episodes of AFib, and it continues longer than 7 days, usually requiring cardioversion to break the rhythm and go back into normal sinus rhythm. And then the fourth type of AFib is permanent AFib, and that is atrial fibrillation that doesn't respond to any type of treatment. It won't respond to any drugs, cardioversion, and may or may not respond to ablations. Okay, so now for the pre-hospital treatment of atrial fibrillation. Initially, you're going to want to do an in-depth patient assessment, a sample history, 12 lead, and you're going to need to get IV access. You want to rule out a MI, myocardial infarction, or any kind of underlying heart issue. You want to be aware of something such as Wolff-Parkinson-White syndrome, which one of the medications commonly given to AFib patients reacts badly with WPW and can actually kill the patient. Excessive alcohol consumption over a short period of time, known as holiday heart syndrome, is also a cause of AFib, especially paroxysmal AFib that just kind of comes and goes randomly. Alcohol can be a trigger. Hyperthyroidism can also be a trigger, and any kind of stimulant use, anything that can irritate the foci in the atria and cause them to fire rapidly. It's kind of thought that if you have the ability to go into AFib, anything can trigger it. Your body's predisposed to go into AFib, and there's triggers out there that can send you into AFib at any time. The treatment objectives for AFib, number one is rate control. Somebody with AFib, especially AFib with RVR, their atria can be firing at anywhere from 3 to 450 times per minute, and their ventricles are going to be doing half that. So if you can imagine someone whose ventricles are firing at 200 times a minute, their heart's going to wear out pretty quickly. So rate control is probably the number one treatment objective. Secondly, you want to get some kind of antithrombotic medication on board, a blood thinner, something like that, because if and when the heart does kick back into a regular rhythm, it can throw out one of those blood clots that's pooled in the bottom of the atria. And then the third thing that they're going to do, maybe not so much in the pre-hospital setting, is a rhythm conversion. And that usually consists of some kind of electric shock, synchronized cardioversion. And like I said, the only time you would need to do that in the pre-hospital setting would be if the patient was unstable and it was a life or death matter. Also, further on down the road, if a patient keeps with the AFib and they're a good candidate for the surgery, they'll do an ablation where they'll go in there and they'll actually disable the points where the atria is firing from, and they'll try to narrow it down to just one point where it's going to send an impulse from, and try to get the heart working relatively normally again. So in the pre-hospital setting for a stable AFib patient, you're gonna do an assessment. You're gonna get a medical history of atrial fibrillation in the patient, when they had it, what started it, how long they've had it, whether they just recently noticed it, or if they've had it for a while and didn't know what it was, or if they've been diagnosed with it before. You're going to want to establish an IV, and you're going to want to transport them and monitor their vitals all the way in. And as long as their rate is under 120 beats per minute, their ventricular rate, there's really nothing that needs to be done, assuming the patient is stable. So a stable patient in AFib with a heart rate greater than 120 beats per minute, you're going to do, first of all, the same assessment. You're going to get the same history of AFib, when it started, have they been diagnosed with it, when did they notice it. You're going to try and find out as much as you can about when this condition started for the patient. You're going to establish IV access, and then through that IV access, you're going to give them cardizem. That's the first line drug for our protocols. And you're going to push cardizem at a slow rate, and it is 0.25 milligrams per kilogram, and you're going to give up to 20 milligrams for your first dose. So any patient that is 80 kilograms or above is going to receive the full 20 milligram dose. The second dose of cardizem, if needed, is 0.35 milligrams per kilogram, and that is going to go up to 25 milligram maximum dose. Cardizem is a calcium channel blocker. It blocks the influx of calcium ions into cardiac muscle cells. It slows down the cardiac muscle tissue and relaxes it. Contraindications to cardizem are hypotension and any kind of allergies. But hypotension is the big one because it's already going to relax the heart and decrease preload and afterload, which is going to lower blood pressure. And so you want to give it at a real slow push, maybe over 5 minutes, 3 to 5 minutes, and just monitor the patient and monitor their vital signs and their blood pressure especially, and make sure that they don't bottom out. The goal of giving cardizem is to control the rate. So the pre-hospital care for a unstable patient, this would be somebody who is unresponsive. You're going to follow the same steps. Try to figure out when their AFib started. The objective for this patient is going to be changing the patient's actual rhythm, since the rhythm is causing them not to perfuse properly. And rate control is going to be secondary, but the main thing you want to do is break that AFib rhythm. This patient is in such dire straits that you're not going to really worry about throwing a clot. If that happens, you can deal with that when it happens, but the main thing you have to do to save this patient's life is to get their heart beating in a regular rhythm again and get them perfusing correctly. The way that you do that is synchronized cardioversion. And you're going to press the sync button on your monitor, and it is going to recognize when the rhythm is on an R wave during the QRS interval, and it will deliver the shock at that point to avoid the R on T phenomenon. You're going to crank up the joules, the energy select. You're going to set that at 100 to 120 on a biphasic machine, and on a monophasic machine you're going to set that at 200 joules. You're going to place the pads front and back on the patient so you're getting a good current through the body, and you are going to charge the machine and then press the shock button. The machine will deliver a shock, and hopefully that will reset the heart and reset the rhythm, and the patient will hopefully go back in a normal sinus rhythm. And then you can take measures to try to keep the patient in normal sinus rhythm, and that may be some type of drug, and it will probably be administered at the hospital. So hopefully at that point, the shock will convert the rhythm back to normal sinus rhythm, and you're going to take the patient into the hospital. Hopefully you've gained some level of consciousness back, and the hospital is going to then start with their procedures and give their medications, which could include cardizem, digoxin, and they're probably most definitely going to put the patient on some sort of blood thinner.